Hello, everyone. Thanks for your patience. We are having a little technical challenge this morning, but we're going to get started. I want to welcome you to the Person-Centered Outcome Instruments webinar on PROMIS, NeuroQol, and the NIH Toolbox. I am Nan Rothrock, and I'm here with my colleagues at Northwestern University, Richard Gershon and Monica Prudencio. We're going to have an exciting morning covering a lot of information. Before we get started, I want to go over some logistics about how this meeting will work. So the first is that you're muted. So if you've got a question, you can't ask it. We won't hear you. You'll need to use the Q&A feature in WebEx. And we'd like you to direct your questions to all panelists. And our team will be trying to answer those questions as they come in, and then also during our Q&A time after each talk, we can address questions. We're going to try to use polling to ask you some questions about your interests as we get rolling. And finally, we're going to be recording this webcast. So if you're not able to see it in its entirety this morning, you can check back and watch the recording, or if there are things you want to share with your own colleagues, this will be available at a later date. If you can't hear me, it's probably because you haven't called in to the conference call number. It's listed here on the screen, and so hopefully you are all able to hear this presentation as well as see it. Our agenda, this is all Central Time where we are. We're doing a quick welcome. I'm going to kick off by providing an overview of person-centered outcome instruments. I'll then hand the reins over to Richard Gershon, who will provide an introduction to IRT and CAT. Monica Prudencio will then talk about data collection options that are available for using all of these measurement tools. And then we'll have a wrap-up Q&A session at the end. All right, so let's get started. Okay. So I'm going to start by providing an overview of person-centered outcome instruments focused on PROMIS, NeuroQol, and the NIH Toolbox. To get started, it helps to share some terminology. I'm going to be referring to patient-reported outcomes, or PROs. PROs are the quantification of symptoms like fatigue or emotional distress, functional status like physical function or cognitive function, and perceptions of health. By nature, they are subjective and multidimensional. So quite often I'm asked, because they're subjective, why bother to ask patients? And there are a number of reasons to do that. First, patients are often the best source of information for particular types of experiences, for symptoms like fatigue or pain, for health-related quality of life issues. Patients are often the best people to gauge that impact of a symptom on continuing meaningful activities. So for example, two people with the same level of pain may have very different impact on their day-to-day functioning because of that pain. Patients provide information about their knowledge, attitudes, behavior, as well as satisfaction, such as their satisfaction with their care. We also know that the same biological value in two patients doesn't equate the same impact. So you might think about a hemoglobin level, and two patients with the same hemoglobin level may report really different impact of fatigue on their lives. We also know that clinician report is extremely valuable, but depending on what's being assessed, there is significant, or can be significant, difference between a clinician report and a patient report. And because of that variability, it's often helpful to have both perspectives represented. And finally, health-related quality of life scores, particularly physical function, have been shown to predict survival in many conditions. We're in the era of a lot of interest around patient-reported outcomes. We're in an era of patient-centeredness, and you've seen this in a number of ways. So the third-level Health IT Meaningful Use Incentive Program has been encouraging use of patient-reported outcome measures in clinical care. We've also seen the development and launch of PCORI, focused on funding patient-centered research, and patient-reported outcomes is a large part of that. So with all of this interest in PROs, one of the things that's been identified is that there are a number of problems with PRO measures, and the first one I want to talk about is often referred to as a ceiling or a floor. Whenever I hear this, I always remember the movie Being John Malkovich, which, if you saw, there were whole scenes of this movie that took place on the 7.5 floor. And so if, for example, we wanted to assess how tall John Cusack is here, and we're in the 7.5 floor, we asked him to lean up against the wall, and we'd measure him against the wall, we wouldn't know how tall he is because he has to crouch down. He's hitting the ceiling of the wall. He's hitting the limits of measurement. And so in the same way, some patient-reported outcome measures also have these limits that at the extreme ends, they're not able to distinguish people. We can see that in this example from a study led by Paul Polkonis. He was looking at individuals with depressive diagnosis who were starting a new treatment, and he measured them at baseline, 1 month, and 3 months. This is showing a person's score on 2 different instruments of anger aggression, so kind of an outward expression of distress. What you see in blue is the PROMIS Anger CAT, computer adaptive test, and it's showing a larger effect size at each time point. What you see in pink is the aggression questionnaire, and it flatlines after 1 month. This would be an example of a measurement, ceiling or floor. I'm not sure the direction the instrument goes. But the aggression questionnaire is not able to capture any change between the experience at 1 month and 3 months, while the PROMIS Anger CAT can capture that change. It's more sensitive to distinguish people at that higher end. And so this is how a measurement ceiling or floor can cause problems in clinical research. We don't know the impact of a treatment because our measurement tool isn't able to be sensitive enough to that change at that level of the trait. So in addition to ceilings and floors, there are other problems with PRO measures. One is patient burden. A number of commonly used instruments are very long, and what that means is it's difficult to integrate into some settings. If you're trying to capture PROs in a busy clinic, quite often there's not enough time. It also means that you have to really limit what you are assessing. You may be able to only focus on one thing rather than several things. And as we mentioned at the outset, these are multidimensional constructs, and often you want to measure multiple things, and it may not be possible with the time available. A number of PRO measures have royalties or costs per use that can be prohibitive. There are psychometric limitations, and quite often significant ones in widely used measures. And Dr. Gershon will talk more about that as we go on. And finally, a lot of PROs don't provide any interpretation guidelines. So a participant may have a score of 18 or 112 or 6, and it's hard to know what that actually means. An additional problem with existing PRO measures is that they don't allow for easy comparison. So an individual who did a research study using the WOMAC, a widely used measure of physical functioning in arthritis, may not be able to compare results with another researcher who used a different measure like the SMFA. This makes it more difficult to compare, combine results, and evaluate different treatment interventions, for example. So quite often people say, well, I think maybe the best option then is to use a disease or condition-specific instrument and to be able to capture what is unique about a given condition. This data is from 2012, from the Centers for Medicare and Medicaid, and what we see is that the majority of their participants have two or more conditions. And so what that means is utilizing a disease-focused or very condition-specific instrument is not going to capture that person's complete experience because it's highly likely that they have more than one condition. So because of all of these issues, the National Institutes of Health were interested in trying to improve measurement options available for clinical research, and that led to funding 3 large initiatives: the Patient-Reported Outcomes Measurement Information System, or PROMIS, the Quality of Life in Neurological Conditions, NeuroQual, and the NIH Toolbox for Assessment of Neurologic and Behavioral Function, or the NIH Toolbox. And I'm going to talk about all 3 of these initiatives. All 3 used a similar approach to measurement development. The first is that they all focused on creating universal measures, measures that could be used across conditions. And so there was a significant awareness of wanting to avoid phrasing like because of my diabetes or because of my arthritis. A second shared attribute is that they all have self-reported health domains that are measured. The NIH Toolbox is unique in that it also includes performance measures. All used item response theory, which we'll hear more about in a little bit. This is a different approach to measurement construction than classical test theory that has been widely used in PRO development. And finally, they were all utilizing state-of-the-science mixed methods, so a tremendous amount of qualitative and quantitative research went into measurement development for each of these initiatives. In the end, the desired aims were to create instruments that would be more widely applicable across a broader range of patient populations, more sensitive to be able to address those ceiling and floor issues, and more efficient to make utilization of PRO measures more easily integrated into clinical research. So let's get started and go through each of these measurement initiatives one by one. We'll start with PROMIS, the Patient-Reported Outcome Measurement Information System. PROMIS developed a set of item banks, and they assess self-reports of physical, mental, and social health. And we'll talk more about what an item bank is when we talk about item response theory. PROMIS was focused on developing measures that could be used across chronic conditions and to develop measures that could be completed between ages 8 and adults by self-report and down to age 5 by proxy report. So a 5, 6, 7-year-old could have a parent report on his or her well-being. The instruments that were developed include computer adaptive tests as well as short form. And finally, PROMIS was interested in creating links between measures, so links between existing patient-reported outcome measures and the PROMIS metric, and did that through an effort called Rosetta Stone, which I'll talk a little bit about later, but it allows one to convert a score on an existing legacy measure, a commonly published PRO measure, to the PROMIS metric. PROMIS has a great website at nihpromis.org where you can learn a lot more about this initiative, view the measures, and get guidance on suggested reading. This is the domain framework PROMIS utilized. So again, it was focused on self-reported health. and divided self-reported health into 3 areas: physical, mental, and social. Each of those break down further into symptoms, function, affect, behavior, cognition, relationships, and function. These are the item banks that are available today in PROMIS for adults and kids in physical health. You can see measures of pain, fatigue, sleep issues, physical function, sexual function. This is being expanded right now. It's also available in Spanish and other languages, and there's a full list of language availability on the PROMIS website if you're interested. PROMIS mental health measures, again, are available for adults and kids. The most widely used of these are the anxiety and depression banks, and there are other banks as well, including anger, psychosocial illness impact, and this is really getting at the impact of an illness on one's well-being, so both positive and negative. So questions about finding meaning and purpose in life, or changing relationships with others because of the experience of having an illness. Cognitive function here is a perception of cognitive function, so self-report of having difficulty with memory, attention, concentration, etc. And then there are a number of alcohol banks focused on use, consequences of drinking, and expectancies for what one thinks will happen when drinking. Again, the mental health item banks are available in Spanish and other languages. In social health, the most widely used item banks that have been developed are ability to participate in roles and activities, so I'm able to do my normal things at school, at work, at home, for example, and satisfaction with that role. There are a number of measures about social support as well. Emotional, informational, instrumental support are all included, as well as measures of connection with others through companionship and social isolation. In pediatric populations, the only bank that's available right now is in peer relationships. Other banks are coming soon, and let me show you those. In adults, there are a number of item banks that will be available focused on symptoms of GI or gastrointestinal issues. There are item banks being developed for self-efficacy in managing a chronic condition, and there will be an update to the sexual function item banks. A lot of development is happening in pediatrics, including a significant expansion in the assessment of pain, focused on pain behavior. So these are activities one may do when in pain. So I grimaced or I rubbed the part of my body that hurt. Pain quality, so this might be issues about the experience of pain, so symptoms like burning or stinging pain, and intensity of pain as well. Physical activity is a self-report of engagement in physical activities. Experience of stress, subjective well-being, the impact of child illness on family. So we had a bank focused on a child's relationship with other kids. This is now focused on the impact of the child's illness on the family, as well as his or her sense of relationship quality with family members. And then a global health measure as well to match the global health measure that's available for adults. So this is an example of a PROMIS instrument. This is one of the pain interference short forms. Pretty short, pretty clear statement, utilizing a 7-day time frame with 5 response options. This is a prototypical example of a PROMIS measure. All PROMIS measures are scored using a T-score. A T-score has a mean of 50 and a standard deviation of 10. It's referenced to the U.S. general population, so if one gets a score of 60, you know that you're one standard deviation above the general population mean. High scores mean more of that domain, so a high physical function score is a good thing, a high fatigue score is not a good thing. And work on minimally important differences has shown that a difference of 4 to 6 points, for example, in physical function, are associated with a meaningful difference. And you can read more about that in a paper by Kathy Yost. For NeuroQual, NeuroQual was also focused on developing item banks focused for self-report in physical, mental, and social health. It also included supplemental domains that were targeted for specific diseases, and one example is stigma, so issues that might be unique in, or more common, I should say, in neurologic conditions. So unlike PROMIS that focused on broad use across all chronic conditions, NeuroQual focused on broad use within chronic neurologic conditions. So, for example, Parkinson's, epilepsy, stroke, ALS. And so the domains that were selected for development were domains that were very relevant in those conditions. Like PROMIS, NeuroQual developed computer adaptive tests and short forms. And it's also included in the Rosetta Stone project. So one can convert a NeuroQual score to a PROMIS score. NeuroQual has a great website as well at neuroqual.org, and I would encourage you to check that out to view measures, watch videos on introductions to different measures, as well as a list of suggested reading. The NeuroQual domain framework is here. Just like PROMIS, it split self-reported health into physical, mental, and social constructs, and then had further divisions of those. The physical health banks that were developed for, again, adult self-report and pediatric self-report. The lighter colored banks are not banks, but shorter instruments. So again, similar content, fatigue, sleep, physical function, pain are all measured. And like PROMIS, these are available in Spanish. The mental health banks, again, include anxiety and depression, which are the most commonly utilized. One unique attribute of NeuroQual is its assessment of positive affect and well-being, so not just the negative affect or distress component. Has a measure of emotional and behavioral discontrol, as well as stigma, self-reported cognitive function, and communication as well, and a smaller set of the same domains in pediatric. In social health, we see ability to participate and satisfaction with that participation, and again, interaction with peers for pediatric respondents. NeuroQual also utilized a T-score metric where the mean is 50 and the standard deviation is 10. It's reference to the U.S. general population or a clinical population. So, for example, stigma may not be appropriate to reference to the general population, but may be more informative when referenced to a clinical population. And again, a high score means more of that domain. Our third measurement initiative is the NIH Toolbox. The NIH Toolbox was interested in providing assessment of neurological and behavioral function. And unlike the other two initiatives that were focused on measurement for individuals with chronic conditions, Toolbox was interested in measurement across diverse populations, including well individuals. The Toolbox also has a lower age limit. It goes down to age 3, all the way to age 85. The NIH Toolbox developed batteries in 4 areas: cognition, motor, sensation, and emotion. And those batteries are sets of instruments that may be computer adaptive tests or short forms, with each battery being able to be administered in 30 minutes. Another attribute of Toolbox that's different than NeuroQual and PROMIS is that it includes the self-report survey measures of patient-reported outcomes like we've seen, but it also includes objective tests. Again, it's available in English and Spanish, and there's a great website at NIHtoolbox.org where you can learn more about the Toolbox. The cognition domain includes 6 areas of measurement: executive function, attention, episodic memory, language, processing speed, and working memory. And unlike the assessment of cognition in NeuroQual and PROMIS, which were perceptions of one's cognitive function, these are proctor-administered objective tests, so specific tests evaluating one's working memory, for example, rather than a self-report of one's experience of remembering. The motor domains are also objective proctor-administered tests, and they include assessment of dexterity, strength, balance, locomotion, and endurance. These require some tools to capture, so strength, for example, is measured with a grip strength instrument. Sensation is also an objective test that's administered by a proctor, and it includes measures of vision, audition, gustation, somatosensation, vestibular, and olfaction. Again, some of these tests require some equipment in order to administer. And finally, in emotion, we have a number of self-report domains. This includes psychological well-being, social relationships, stress and self-efficacy, and negative affect. The NIH Toolbox scores are available for the PRO and performance measures. The mean is 50 with a standard deviation of 15. And there are a variety of different scores that you can utilize based on your purpose. This includes an unadjusted scale score, an age-adjusted scale score, and a fully adjusted scale score, which is adjusted for age and other demographic characteristics. You can also use the self-report raw scores using the same metric as PROMIS, a T-score with a mean of 50 and a standard deviation of 10. There's a scoring manual that can help you identify which score is most appropriate. So from these 3 initiatives, there are several advantages over existing instruments, and I want to go over some of those quickly. So the first is improved measurement. The increased power that allows for reduced sample size. Sorry about that, we had a little technical issue. So one of the advantages to newer instruments is their improved measurement, and I'm going to talk about that in a couple of ways. So I want to start with this rather busy graphic, and I'm going to take a moment to explain what we're looking at here. On the x-axis, we see physical function scores. You can see the mean for the U.S. general population is right around 50, and the mean for a rheumatoid arthritis population is lower than that. They have lower physical functioning with a mean somewhere around, I guess, 32. On the y-axis, we see error. High error is bad. We want to have the error as low as possible. And within the heart of this graph, then, we see different measures that are showing how different instruments perform dependent upon one's level of physical functioning. So let's start with the SF-36. The SF-36 includes 10 items assessing physical function, and what this plot is showing are individuals' score and error. So what we see is that the SF-36 is measuring just one part of the range of physical function, and the error term it's a little high at points, and so these two blue lines indicate common cut points of desirable error you want to be below. So the measure has some limitations in that it's not able to capture individuals who fall above or below this range, and the error term is higher than desirable for part of that range. Another common legacy tool is the HAC. The HAC is a 20-item instrument indicated by these red dots, and it was developed in arthritis populations. And you'll see it does a fantastic job at assessing people at this very low range of physical function, but it does not do a very good job even at the general population mean. And so if you have a sample where you're expecting people to function at least as well as the average U.S. Citizen, then we're not going to have a way of capturing that. If we look at some of the PROMIS measures, then we can look at short forms and CAPS. So for the 10-item short form here in a green line, you see it's covering a really large range of the trait of physical function. Still has a measurement ceiling here. If we look at a 20-item short form in red, we see it's a more precise measure. The error is lower, covering a little more of the range, but it still has its limits. And then in blue dots are the computer adaptive tests, and you can see it's covering the broadest range with the lowest level of error and with only 10 items. So there clearly are advantages of using a computer adaptive test if you want to have a very precise measure across a wide range of a trait. Here's a similar set of graphics from NeuroQual. This is showing various NeuroQual domains and their item bank information functions. So where on the trait are they measuring well? So what we see in red is a line indicating at what range of the T-score does this bank assess. And the blue box is kind of an indication using those cutoff points about where we have good, reliable measurement. And we can see that across these domains, there is a range centered around the mean of the U.S. general population with a little variation on how fat or wide that range is, so how much of the trait it is able to assess well. Another way we look at improved measurement is through responsiveness, and there are a number of ways to assess responsiveness. I'm going to look at effect size. This was one study done by Kathy Yost and colleagues showing in a cancer sample a comparison between a physical function short form from PROMIS and the SF-36 PF10, a 10-item physical function measure. And what we see are patients who reported doing better, the same, or worse than an earlier time point. And we're comparing effect size between these two measures. And it's pretty comparable for patients who report doing better or about the same. But here we see the PROMIS measure is doing a little better at capturing deterioration from 2 time points in this sample. So it's showing more responsive measurement. Another advantage to these newer instruments are their adaptability, and this is an inherent attribute of item banks built using item response theory. This is a graphic that was constructed by Man Hung and colleagues in orthopedic population. On the left, we have a graph showing the distribution of physical function in a sample of orthopedic patients, with patients with high physical function falling up here and lower physical function falling towards the bottom of the screen. On the right, we have graphed items. So what she's done is shown where an item falls on this same range of physical function. And you'll see that if we were to draw a curved line around each of these, they wouldn't match up exactly. In classical test theory, this would mean this measure is going to have a ceiling. It's not going to be able to distinguish between people at this topmost point and a little lower down. One of the advantages of item response theory is we can write and calibrate new items and add them to the item bank to extend the measurement ceiling a little higher. And we're doing this work right now so that the physical function item bank does a better job at distinguishing people who are at that athlete level. Another advantage of newer PRO measures is the low patient burden, and we see that by completion time. Here are some data from a couple studies focused in orthopedics, comparing completion times for PROMIS CATS and other widely used measures in orthopedics. We see really fast completion times, even among folks who had some limitations with physical mobility and age. The graph shows the PROMIS completion time on average of 1:45, the constant at 1:51, DASH and SMFA at 6 minutes 50 seconds, 8 minutes 21 seconds. So what this means is you can capture this quickly, so you can integrate it into routine clinical care, or you could measure more than just physical function in the time you have available. Another advantage to these newer instruments are their comparability. I can show this within PROMIS. Because PROMIS is not focused on a single chronic condition, but is really assessing a universal domain, we can compare across different conditions. So we've done that with fatigue in this slide. So we have a x-axis showing our mean of 50 for the general population. We administered the PROMIS fatigue instrument in a sample of COPD patients, both those that were stable at the time and those that were in the midst of an exacerbation, so they were having more trouble with their breathing. And we also looked at those who were in an exacerbation and then at a later time point became stable. And we can see, as expected, those who were having an exacerbation were having higher level of fatigue than those that were stable, and that over time, with the reduction in symptoms, their fatigue improved. We can also look at heart failure. So these were patients who were waiting a transplant, had pretty significant levels of fatigue, almost a standard deviation above the general population mean. And after getting a transplant, they had a massive reduction in their fatigue, so below the general population mean. For depression, at baseline, we see really high levels of fatigue, and then after treatment of 1 month and then 3 months, we see reductions in that symptom. Back pain patients also report high levels of fatigue that improves with treatment over time. And cancer patients who are receiving chemotherapy also show an improvement of fatigue when their chemotherapy is leading to benefits to their health after 2 months. So this is a interesting and unique aspect of PROMIS in that we can do these comparisons to look at fatigue levels across so many different chronic conditions. Another way instruments are comparable is through this effort I discussed earlier of prozetastone. Rosetta Stone created legacy instrument to PROMIS instrument conversion tables, and it includes a number of widely used legacy measures. Right now on the Rosetta Stone website, you can look at tables for the brief pain inventory, the CESD, the functional assessment of chronic illness therapy, the HAC, SF36, PHQ-9, and others, with more being added in coming months. Here's a sample table that will show, for example, the SF36 PS10 score of 17 converts to a PROMIS T-score of 37.2 with a standard error of 2. So this allows you, if you're interested in transitioning to a newer instrument, to be able to link back to existing data sets that you may have. And finally, an advantage to these tools is that they are royalty-free. So they are available for use in clinical research and practice without cost. So we've gone over 3 different measurement initiatives, a lot of different domains. It begs the question, well, how do I choose a measure? I would start by identifying your population. If you're working with a neurologic condition, obviously NeuroQual should take a deeper look. If you're working in a population that may be of interest to include some objective test measures, Toolbox may be of interest. Age is an issue. If you're looking at young kids, how young are the kids you're assessing, and if self-report or proxy report is applicable. The domains can also provide some guidance. So you can review domain definitions. I'm going to click on this and see if I can share with you the domain definitions. Hang on, I don't know if you can see it. I need to share.
Yeah, we're not seeing.
Okay, so I need to share, let's see how I do this.
Application.
I'm gonna, all right. All right, so this is the PROMIS website here. Here we are on the PROMIS website, and there's a page that shows all of the definitions. This is a great place to start, just to do a quick review to identify if the way PROMIS define these constructs matches what you're interested in assessing. Oh, and I lost my place. Another tool that's really helpful are the PROMIS scoring manuals. I'm going to try sharing one of these as well. The PROMIS scoring manuals are more than just instructions for scoring, but they provide information about how instruments compare with one another, decision points you might have about whether I want to use a self-report or a proxy report tool, and also some additional information about a given domain. So I'm having a little trouble opening that up, but if you were to go to assessmentcenter.net and look for scoring manuals, you would find them there. Another way to consider what measure might be appropriate is to identify why you're even measuring in the first place. If it's for screening purposes where brevity is critical and you care less about the precision of the measure, or if it's your primary outcome where a longer, more precise measure may be more necessary. And finally, the completion time. How much time do you have to do your assessment? So to identify whether you can include 3 or 6 domains, whether a computer adaptive test might be advantageous over a longer short form, that can also be a helpful tool in deciding what to include. To learn more, I would strongly encourage checking out the websites here, NIHpromis.org, NeuroQual.org, and NIHtoolbox.org. All of these sites have video tutorials that you can watch to learn more about the measure initiatives themselves, as well as lists of publications and a number of manuals that provide a lot of detailed information. All of this work was supported by NIH funding that I've listed here, as well as funding from the AO Foundation, and we're very grateful for their support. So that is the end of my presentation. I'm wondering if there are questions that have come in that I can answer at this time. I'm looking at my co-presenters, and I think they've been able to answer everything that's come in, so that's great. We're suddenly ahead of time now, so that's super. So at this point, what I'd like to do is turn the microphone over to my colleague, Richard Gershon. Richard is Vice Chair of the Department of Medical Social Sciences at Northwestern University. He has been a principal investigator of the PROMIS Technology Center and of the NIH Toolbox Initiative, as well as being involved in the NeuroQual Initiative. He is a card-carrying psychometrician and is going to talk this morning about item response theory and computer adaptive tests. So,
thanks, Nan. I'm looking for my card, but let's see here. Man, you're going to need that one, I'm afraid. Okay, let me do a little quick switch here. Sharing aid application. Stop sharing. I'm just switching over here, please. And great. And 1 second here, and we'll be started again. Whoops. And RTCam workshop. And okay. Well, hang on a second here. Fine. Decline that. All right, one more try here. Well, it just doesn't want to let us look at, there we go. All right, and slide. Yeah, I'm trying. Here we go. Okay, got it. Let's try on the top. Okay, great, and we're up and running. So we're going to talk for a little bit, about an hour, about item response theory and computer adaptive testing. This theory and this mode of assessment are used frequently throughout all the measurement systems we're talking about today. This presentation is applicable, I sometimes like to call it the IRT and CAT for dummies, but we won't be doing anything that puts you over the top, and if you're another card-carrying psychometrician, it's time to take a coffee break. So, first thing we're going to do is we're going to talk about item response theory and how it compares to classical test theory. And if you don't know what that is either, actually you do, but we'll outline that a little bit. And then we'll talk about how we can use IRT for item banking, to create short forms and computer adaptive tests. So let's take a step back and just talk about measurement. A lot of us usually forget this step, and people always want to create an assessment and how do you do the test and what are the questions. And it's always good to go back to the beginning because it actually helps us to understand the complicated components. And we've got to remember that measurement requires the concept of some kind of trait that we can discuss in terms of more or less. If it's not variable, there's no reason to assess it. And test items are the operational definition of the underlying trait. And indeed, if you look at various assessments, you really, looking at the name of it or how they define that assessment is nowhere near as important as actually looking at the items themselves. I recall my first International Society of Quality of Life conference, and I counted 40 assessments of fatigue that had been sponsored by the NIH, and all of them have slightly different items, and therefore they all measured something slightly different. So then test items themselves can be ordered from easy to hard. Now, we don't usually think about it in this way, but we can think about it easier with math. So obviously a second grade math item is a lot harder than a fourth grade or a sixth grade or an eighth grade item. And the same thing happens if we're talking about quality of life. Something like physical functioning, someone who has trouble running an errand is quite different than a person who can easily walk around the block, which is, you know, much less than a person who jogs every day, which is much less than an athlete. And so these items can be ordered from easy to hard. And similarly, we can order test takers, assessment takers, or survey takers from less able to more able. And you're going to notice I'm going to use terms interchangeably like easy to hard, able to more able, high or low on a trait, because from a measurement perspective, it's all the same. And very often in my work, I don't really care if I'm talking about vocabulary ability or pain. They're both, to me, these are things that are on a continuum. And I have people at one end of the scale and the other end of the scale. And if we look at it in those terms, we can see how measurement theory can be applied to all sorts of assessments. So IRT, item response theory modeling, is latent trait modeling. Latent trait is an unobservable dimension, okay, that can give rise to a set of item responses. So we have a simple item, I'm too tired to do errands. Not sure if I like that grammatically, but at the far end of the left, false. Those are people who are going to be energetic. And on the right, severe. So it's a simple item that can, in giving true-false answer, I roughly divide the population in two. I don't do it very accurately. But again, what are we doing? We're getting, by asking a question about an errand, we get at fatigue. Because I can only ask about a person's fatigue. Do you have fatigue? Yes, no, true, false. So what we have to do, particularly in patient-reported outcome measures, we have to circle in on activities or statements that are reflective of the underlying trait, in this case, fatigue. So when we're talking about fatigue, we talk about continuum of severity. A continuum of the construct. We know that on one hand, absence of fatigue is associated with active people, and at the extreme end, we know absence of fatigue is probably associated with athletic people prior to the race, not after the race. And severe fatigue at the extreme end is a person who literally is never waking up. So why do we care about this using IRT? Well, generally, depending on what type of IRT, we can have equal interval measurement, and varies a little bit depending on the type of IRT, which is probably a little deep for our discussion today, but we can create a numeric scale where the scale has meaning, similar to like a shoe size or a yardstick. We know the difference between 6 and 7 inches is the same as the difference between 35 and 36 inches, and I can't say that using a lot of fatigue or a little fatigue, that scale doesn't help us. I need to quantify that. The other thing is test takers and items are represented on the same scale. So if I have an item at 65, it corresponds to a person at 65. Kind of the same thing as if I have a 7th grade math item, I can associate a 7th grader with that item. Now, a really nice thing is item calibrations are independent of the test takers used for calibration. This is a relatively new science. It used to be that if we had a set of items and they were going to be relative to a group of people, we actually had to re-look at those items on each group of people. But IRT lets us separate that out, and we'll talk about that in a little bit more detail in the next few minutes. And similarly, candidate ability estimates are independent of the items. So I can give different sets of items to different people and get a score on the same scale. And again, we'll go into detail. And finally, measurement precision is estimated for each person, each item. Let's go a little deeper. So test takers and items are represented on the same scale. So item difficulty, these are all synonyms in my book. Item difficulty, severity, measure, theta, item calibration, location. If you see articles on item response theory, these terms are used relatively independently. And similarly for person ability, measure, theta, person calibration, location, they're the same because I can put them both on the same metric. So let's see, here we have a physical functioning item bank. The items across the bottom. Across the top of the page, we have items. So are you able to get in and out of bed? Okay, that's an item that's best used for a person who has been having trouble getting in and out of bed. Okay, it's not a particularly good item for the person who's been bedbound for weeks on the left, and it's not a particularly good item to give to somebody who's a marathon runner, right? That would be a waste of effort to give that item to a person. But in our bank, we have an item able to get in and out of bed. Are you able to walk a block on flat ground? Okay, that's a good item, again, for a person who's, you know, can ambulate, but not great, but, you know, they're at that stage in their functioning. Are you able to run 5 miles? And, whoops, skip ahead here. Okay, some other basic terms, just so when you come away from here you have some what might be conceived as interesting lunch and chat available. Discrimination, we can actually find to what degree an item discriminates the person ability. So is that item spot on, or is it a little bit distant? Item information, where an item discriminates. So a 7th grade vocabulary item does a great job of discriminating 7th graders, but probably does a horrible job of discriminating 2nd graders or college students. And the same thing applies in our physical functioning example. Using an item that I can run 5 miles does not give us good information about a person who's bedbound or recently bedbound. And test information is the area where the test discriminates. And Nan was showing some of these information curves in the earlier presentation. So again, the math example, a 4th grade math test probably gives good information from 3rd to 5th grade. Does not do a good job on college students. So when we're looking, item response theory allows us to ascertain where a test does a good job and where it does not. So every item in item response theory has statistics about it, or parameters. And the primary one is item difficulty. And item difficulty is simply where along that continuum that item rests. Next is item discrimination. We talked about that. Also guessing. Guessing is a parameter that only comes about in multiple choice ability items. So it's not applicable to fatigue. But if I have a multiple choice vocabulary item, there is some chance that a test taker will guess that item correctly, and we can actually model that. And I have here lots of other looking numbers. Let me say what some of those are. So here's the basic item characteristic curve. Any basic course in item response theory will show this curve, or some more that I'll show you in a few minutes. And along the bottom, we have the person, for a given item, a person's proficiency. And if it matches the person, that would be at 0 along the bottom. A person typically has about a 50% likelihood of answering that item correctly. It can be manipulated. But you can see a person who has no ability, -3 off to the left, on this particular item on the y-axis has about a 22% chance of answering this item correctly. Right, so this is clearly for a multiple choice item. Okay, and at the high end of the scale, a person has a very high ability, much higher, so this would be an 8th grader answering a 2nd grade math item. They have a 1.0 or 100% chance of answering that item correctly. And this curve looks like this frequently, but it will change for each and every item, and we're showing this relative to the person's ability. So some of those other ugly numbers, but actually are very helpful, is something called differential item functioning. And we can actually look, does an item have different parameters, different statistics for different subgroups? So for instance, do males and females respond to an item differently? Now, if you look at the promise items under differential item functioning, you're going to find that almost none of the items have differential item functioning. And you'll say, Richard, then why is this important? And I'll tell you, well, what we did is we got rid of all the items with basic diff from those banks. But diff isn't necessarily a bad thing. We just have to take it into consideration. And I always hate getting into gender differences, but I'll give you a basic one. And that is that for the item, you know, do you, how often do you have tears in your eyes during the week? And it turns out that women say that more often than men. Now, I'm one of those guys. If I go to a sappy movie, I can get a tear in my eyes. I'm willing to own up to that. But it would therefore appear, if that's on a depression scale, that women are more depressed than men. And that's simply not true. It's just that women and men respond to that differently. Men withhold emotion. And so in the promise banks, you won't find an item like that. High stakes tests particularly don't want to deal with race in items. Age can be different. Different generations view and respond to items differently. And in theory, there's disease-based diff. Now, promise doesn't deal with disease-based diff, but you could take that into consideration, although it rarely applies to promise items. The nice thing here I'm pointing out with item response theory is we can actually assess this. Generally speaking, people get rid of items with diff, but it is possible to take into consideration. It would be fine to have a different scoring system for men or women if you wanted to have items that were gender-specific, and oftentimes gender-specific items make more sense to given genders, and same for age, and race. The nice thing is IRT allows us to capture those differences and utilize them if we want to. So there are three main families of IRT models. One's the Roche model, or the one-parameter logistic model, and I should tell you that if you are a Roche person, you might differentiate. It's one parameter. There's a little bit of a difference here. It's too complicated, but the math between them is the same. The two-parameter logistic model, three-parameter model. Now, this is going to be the kind of yawn part of my presentation, but I want to give you enough information so you can pass the test we're not going to give at the end here. So my next section is entitled, How to Choose an Appropriate IRT Model, or My Religion is Better Than Your Religion, because we're getting pretty close to religious differences here, and there is no right answer, although each group who's a proponent of these models will tell you that their model's right. So I did tell you this was the IRT for dummies, but I did a little white lie here. So you're about to see mathematical formulas. If you get anxious about these things, you may want to avert your eyes for a moment. So the one-parameter logistic model is this funky little formula here, but you'll notice the big important thing is that the variables of their ability minus difficulty. So the Roche model, or one-parameter model, looks at how far distant is a person's ability to the item difficulty, and that's all it looks at. So I can ascertain how well a person's going to do on a test if I know their ability level and the item's difficulty level. And indeed, the basic one-parameter equation resolves to, if my ability equals the difficulty of the item, I have a 50% likelihood of getting it correct. So if I'm a 7th grade, second month math student, and I have an item that's a 7th grade, second month item, I have a 50% chance of getting it correct. Now, by the way, I could give people easier items, and they can get higher percent likely correct, or harder items. But right on the money, I can predict exactly how likely the person's get it correct. And actually, this 50% is a nice point, because I can give my most efficient test if I give people items at that point. They're a little hard compared to what people are used to, but I can figure out giving items that are appropriate for that person. And we'll talk about later. Why do we like the one-parameter model? Why? First of all, it's the only option for small sample sizes. So if you have a rare disease, or you have a small population you're dealing with creating a test for, this is the only model that will work. The other models we're going to talk about require quite a few more subjects. Very often, it's the real model underlying a test labeled three-parameter. I've been a testing consultant for most of the large testing organizations, certification organizations in the country at one time or another, and I will tell you my non-disclosure agreement says I can't tell you who these people are, but very often people are touting in the ability space, we use three-parameter model, but underlying it, they're just using the one parameter. It's easy to operationalize, does a nice job, it's less costly. It's the parsimonious solution, the simple solution. Whoops. Okay. Two-parameter logistic model. Okay, this adds one more thing. It adds discrimination. This isn't bad discrimination. This is good discrimination. And this simply says, in addition to the difficulty of the item, we know how well that item discriminates. Now, in the most simple form, the way to think about discrimination is if I have a true-false item versus a multiple-choice item, the multiple-choice item will discriminate better, right? True-false, I'm either one or the other. If I have to guess that I'm two choices, multiple choice, let's say I have 5 choices. I can narrow in the person's ability better with a multiple choice item than the true-false. Now, it turns out even multiple choice, 5-choice multiple choice items vary in their ability to discriminate. Sometimes they discriminate better than others, and I'll show you some illustrations of that in a little bit. So this is a basic two-parameter logistic model. You can see if you're ignoring that E, by the way, is a natural logarithm, which is just kind of ugly to look at. But you can see here we just have two things up there we care about: discrimination, item difficulty versus the person's ability. So here are some graphs. These are the item response theory curves for two-parameter model. Do I have? Oh, I have a little. I don't. Can you all see the arrow on the screen? Not my screen, your screen. Great. Okay, so here we have these all have the same item difficulty, but the discrimination varies. And you can see here that this is relatively, let's see, our best item is one with a very steep curve, because we know definitively if a person gets it right, their ability is at least this high. They get it wrong, it's at least this low. The less steep the curve gets, the less it discriminates. And actually, if you see these graphics should be reversed. But in other words, the steepest curves gives us the best discrimination. Okay, three-parameter model. Now, by the way, this is not applicable to outcome measures, but for those of you who are interested in ability, keep listening for a minute or so. The reason it's not applicable to self-report measures is we assume nobody's guessing. In other words, we assume that their rating of themselves is correct, and we know there's inaccuracy. That's not needed. But this model adds this C parameter guessing, okay, because we know that a person on an ability item could attempt to guess it or might not have any idea, but since we allowed them the opportunity to multiple choice. So what about three parameter? It requires a large sample size, very often 1,000 or more participants. Theoretically, this is the best model. I don't think there's any question that if you know the item difficulty, you know its discrimination, you know its guessing, you know a lot about that item. It makes the most sense. I will tell you that in practice, it makes little advantage over the one-parameter models for many of the applications. And those organizations that publish about the difference between 1, 2, and 3-parameter models are typically organizations like ETS that have tens of thousands of respondents, but most of us don't have that many. So here's a graphical difference on a 3-parameter. These two items have the same, the major difference here is the guessing parameter is 0.10, 10% likelihood of getting it correct. So even if my ability is far below the item, I still have a 10% chance of getting correct, as opposed to a guessing ability of 0.25, 25%. Now, if this is an open audience, I'm going to ask and answer my own questions here because it's hard to do in a webinar format. I'd say if I have a 4-choice item, what's the likelihood of getting that item correct? If you don't know the answer, and I would trick a person into saying 25%, right? I have 4 choices, 25%, and you'd be correct. If it was a monkey taking the test or a random number generator, it would pick the right answer 25% of the time. But a well-written test actually has the guessing parameter at much less than that, because it turns out a well-written test item actually fools people into responding to one of the wrong answers more, that you're able to look at the parameters and see and create items that people with low ability, it's more appealing to pick the wrong answer than the right answer. And indeed, where possible on different types of tests, they actually create tests made up of items where your likelihood of getting it correct is less than 25%. And that's what IRT allows us to look at that. And then there are polytomous models. That's almost an ugly word. Polytomous in our case meaning multiple answered models. And that's what all of our patient-reported outcome measures are. And so in the one-parameter arena, they're known as a rating scale model and partial credit model. So there are different ways of doing this. And I'm not going to go into details on these here if we have time, but at the end of the day, we might spend a look at these a little more in detail. And two-parameter model, graded response model, and generalized partial credit model. And I should tell you for the PROMIS instruments and most of the NeuroQual and NH Toolbox instruments, we do use a graded response model. Now, there's a decision early on within the PROMIS development cycle, and there's several papers on this, that while both grade response model and the some of the one-parameter models have been shown to be useful, that there'd be value in using a common model across everything. Depending on which model is better is kind of based on whose statistics you use to tell, but I will tell you that generally speaking, in short forms and computer adaptive tests, which is what we're talking about today, you probably get the same score regardless of model you use, but again, we're using the graded response model. So graded response model is a two-parameter model that's used for multiple correct answers, right? Multiple correct is, I'm too fatigued to run an errand, never, some of the time, usually a lot, things like that. Those are multiple correct responses. Okay, now if you're really looking for that trivia at lunch, there are also things called multidimensional models. And that is where we can actually use one set of items and create two test scores at the same time. This would particularly be the case of there are good items for assessing, let's say, depression, anxiety at the same time. PROMIS does not make use of these items at this point, but you can actually create two scores from one item. That's almost above my head, so we're going to leave that for another day. Okay, so how does IRT, item response theory, differ from conventional test theory? So in classical test theory, this is what we all did through grammar school. Most of us did through, most of our tests through high school and college also. You take a test, if you have a high score, or we look at their score, and we compare people based on their raw score, right? If you have a high score, you're higher on the trait, low score, you're lower on the trait. I get 90%, I get an A, 80% B, etc. Now, let's go back here a second. What's the problem with this model? Well, if you're in the hard teacher's class and you get 85%, you get a B. And if you're in the easy teacher's class, you get 95%, you get an A. But it turns out that that hard teacher's test is much harder, and the truth is their 85% was worth a higher grade than the easy teacher. And classical test theory can't easily take that into consideration. So IRT is really based on the concept of this first bullet. Each individual item can be used for comparison purposes. And my new way of discussing IRT is that in IRT, every item is a test by itself. So it has all the statistics typically associated with the test. And what we usually do is we combine these items into longer tests. And anybody who's used to doing tests, you know if we test a person twice, we're going to get a more accurate test. Well, item response theory says if I give 3 items, it's kind of like giving 3 tests. So the difference here is if I endorse harder items, I'm higher on the trait. And if I endorse easier items, or like I'm fatigued all the time, I'm lower on the trait. And so IRT says looks at the difficulty of the item, not just the total test. We'll go into this a little more. That's probably not immediately obvious what that means. Let's also talk about reliability. Reliability is the score reliable? If I test a person, is it likely to be what their score is? I mean, a common test of reliability is test-retest. If I test a person twice in a row, do I get the same score? And so reliability, and by the way, there are plenty of tests. They're not reliable. We give the test, and I give it again, I get a completely different score. So that's not helpful in any clinical or research environment. So in classical test theory, CTT, reliability is based on the total test. We have a single number for reliability. If you look in the technical manual, you're going to get one number regardless of patient ability. We'll go into that in a second. In IRT, reliability is calculated for each ability, and it varies across the continuum. So that we know in IRT that if I have, I'm going to go back to an ability test, I think it's easier. I've got a 4th grade test, probably pretty reliable for 4th graders. It's a little less reliable down 3rd grade or 5th grade. It's not reliable at all if I'm using that test to test college students. But guess what? In classical test theory, it doesn't differentiate. Okay, it has one reliability number. IRT actually gives us the level of reliability depending on how far away a participant is from the center of the test, or how far the information goes. And typically that's in the middle of that item distribution, but for PROMIS, we're actually able to spread that reliability, high level of reliability out pretty far. And Ann Rothrock showed in the first presentation how reliability changes for different types of tests. Validity. Is it valid? Is it measuring what it's supposed to be measuring? A typical way we measure validity is measuring against the previous gold standard, but is it, tests don't necessarily measure what they say they are. So classical test theory, validity is based upon the total test. If you give only part of the test, you have to revalidate it with a new sample, or you have to reassess it. In item response theory, validity is assessed for each and every item. So we can take subsets of the items, either a full-length test, a short form, or a CAT, and we'll get into what those mean in a few minutes. But they all inherit the validity assessed to the original item bank. So it's very easy for us to modify tests, create different test forms, and we don't have to revalidate them. This saves tens, even hundreds of thousands of dollars if you need to use a different type of test form for a particular study. So how scores depend on the difficulty of test items? So let's look here. So I have a very easy test. I've got 8 items. They're far below the ability of the person. We'd expect that person to get a score of 8. On a very hard test, all the items are above the ability of the person. We'd expect them to get 0. And a medium test, and by the way, this is a medium level test relative to the person, so that it bridges the person's ability level, they'll probably get a score of 4 or 5. Okay, now we know this, it's intuitive to us, but item response theory allows us to quantify this in much easier ways than does classical test theory. So in raw score terms, we think I get on a 4-item test, get a score of 1, 2, 3, 4. In our heads, we view the difference between 1 and 2 as being the same as the difference between 3 and 4. But this 4th item is much harder, and therefore the difficulty is higher. And item response theory quantifies this. So we understand the difference here between 1 and 1.25, 1.215, 1.50. But if it's a much harder item you pass to get that score of 4, then your ability jumps accordingly. So now let's look at this in terms of a multiple choice item. In traditional test theory, I have a lack of energy, not at all, a little bit, somewhat, quite a bit, or very much. We see we have a score of 4, 3, 2, 1, 0. And in our heads, we approximately say people are going to divide evenly or these scores mean the same thing. But we know using item response theory that indeed, now what we've done here is the PROMIS metric, Dr. Rothrock mentioned this earlier and I saw several questions in the Q&A session said, what does this metric look like? So I'll review it now. So 50 is the mean on the PROMIS instrument of the general population for almost all of our instruments. So we went out, tested these instruments in a general population sample as well as disease-based samples, and we decided to make the scale easy to understand that 50 is the mean in a general population sample, originally centered for the 2000 census, and we will have new centering available later this summer for the 2010 census, but 50 is the mean for the general population. Now, it turns out that people who say, I have a lack of energy, not at all, their actual scores on the scale fall between 0 and about 38. Okay, it's not an even chunk down here at the bottom. It is 38 scale score units, so that's about almost 2 standard deviations to 5 standard deviations below the mean. Why do we know that that's our level? Well, we gave hundreds and thousands of people a full-length fatigue scale, tens or dozens of items, depending on what study, and we found out their actual level. This also goes to show if I give one item, I get some information, but if I want more information, I need to give more items, and we're going to see later today, not as many as we think we need to give. We can also see people that say a little bit, generally are in this area here, somewhat fall between 45 and 60, quite a bit, go up to 75. That's 2.5 standard deviations above the mean. People say very much lack of energy. These are people who are very, very fatigued. Go from 2.5 standard deviations above the mean to 5. It's a very wide range. Now, I will have you note, this makes life look very neat, that for sure everybody's in these boxes, and unfortunately life's not so simple. But that is by odds where they're going to be. That's the most we know with one item. Okay, let's also look at the IRT reality of a 10-point rating scale item. I'm never sure why we call it 10-point when it starts at 0, which to me means 11 points. We've all seen this FACES item. It's the most widely used outcome measure in the world. It's in almost every emergency room in the world. It's in many patient rooms. You can't get all sorts of treatment without saying, first, what's your level of pain today? Our colleague, Jinsei Lai, ran a study that, well, what if you gave people this item, but also gave them a full-length pain scale? And it turns out that people say no pain actually cover almost a third of the trait range. So even though they say no pain, depending on their life experience and answering a more complete pain scale, they actually cover quite a wide range of the pain continuum. And ditto, people who say they have the very worst pain, some of them really have high pain, they do go down to close, starting at almost about 1 standard deviation above. It really depends on pain tolerance. The most disturbing thing to me is the differences between 3, 4, 5, 6, 7. You see that these people, anybody who answers in this range, is actually very tight in terms of the level of pain they actually have, based, again, on giving them a longer survey. And the problem with that is that there are standard operating procedures clinically in many hospitals or in clinics saying, well, if a person goes to 3 to 4, we give them a drug. If they go from 6 to 5, we take them off a drug. And you can see the actual differences between that are very minor. And yet we rely on this item greatly. By the way, single items are fine for population measures and perhaps fine for even some kind of trial, but relative to accuracy for an individual patient, clearly they can't be very accurate if people aren't really differentiating very much in this middle region. So here's the item characteristic curve for a palidomide item. So remember, we had that nice simple curve before for an ability item, and I showed you that for 1, 2, and 3 parameter item response. It was a simple curve, kind of looked like this blue curve here. Well, it turns out for a palidomide item, we have a different curve for every single response. So, whoops, let's go back here. Here's that simple, remember I said before, look, here's the not at all, it covers this range. Well, that's true. That point roughly aligns with here. So if I say not at all, my score is likely to be in this range here, again, from about 3 standard deviations below to 5 standard deviations below. That lines up here. But we should note that if we give this item to thousands of people, that there is some likelihood that a person who says not at all could be as high as 2.5 standard deviations above the mean. So we look at this curve. It is possible. Let's go here. Let's go the other way first, because if I say very much, likelihood is most likely that their difficulty is in this range here. But you can see there's somebody who says a lack of energy very much. They say, I'm really, really tired, that actually they have more energy than half the population. There are some people down in here. Again, this is the danger of giving a single item. While the person is most likely to be here, there are some people who are down here. So if we give a single item, that's the risk. We can see this similarly for each option. I have a lack of energy quite a bit. Some of these people are bedbound. They aren't functioning at all. But some of them go down to some of the most, let's see, a full 2 standard deviations the other direction. So they are what? Have the 95th percentile of energy, right? So again, one item is a little inaccurate. Again, I have a lack of energy, somewhat, almost covers this whole trait range. Now again, if I'm averaging 100 people, this is fine, but I'm looking at an individual patient. Look, they say somewhat, they might be 4 standard deviations below, they might be 4 standard deviations above. And similarly for quite a bit, and again, not at all. So these are the people who say they're energetic, basically, and some of them are quite energetic. That's the likelihood, but some of these people really are some, 2.5 standard deviations above the mean for level of energy. Now, this is not a bad thing. So people say, oh my gosh, what's going on here? This is a reality. This is what IRT allows us to look at and doesn't hide it. But we can utilize this information to improve our assessment model. So here's another item. I've been too tired to feel happy. This is actually a pretty good fatigue item, okay? And so, again, and we can see what we like here. And again, a lot of these curves, they say, oh, that's ugly, Richard, why are you doing this to me? But I like them. They're steep curves. If I sum this item with lots of others, I can zero in a person's ability level. I felt energetic. Now, this is a good example of an item I wouldn't give to a person if I could, who was pretty tired, we knew in advance was tired. That would not be a good information level use of this item, just like I wouldn't give a 4th grade math item to an 8th grader. I wouldn't give a I felt energetic item to people who are bedbound. And you can see, because people say none of the time, we don't know if they're over here, but people who say all the time, most of the time, sometimes they're in relatively narrow ranges. I've been too tired to read. I like showing this item. First of all, it is a good item. Notice the discrimination is less. Our curves are not as steep. Now, the reason they're not as steep is if you don't like to read, you might always be too tired to read, right? I've had kids, I've got a few kids, and I've had some non-readers at points in time. And you better believe when it comes to bedtime, oh, Mom, I'm too tired, Dad, I'm too tired to read. They're not too tired to text their friends, mind you. But a person who loves to read is almost never too tired to read. So it's a good item, but this shows an interesting component of going to outcome measures. We are asking about activities related to fatigue, and some will be more or less appropriate to individuals. That's why we do want to usually give more than one item. Okay, let's change topics to item banking. We can use item banks to create different kinds of instruments, and I'll break this down right now. So first of all, short forms. PROMIS, NeuroQual, and Toolbox have short forms available for many of the assessments. Short form is typically 5 to 7 items, as many as 12, as few as 1, 2, and 3. And what it is you can create a short form to either cover the full range of the trait, or you can do it to cover a narrow range. Let's look at that. So we're back to our physical functioning item bank that we looked at before. I could have what I'm going to call physical functioning form A. This might be something I'm using in clinical treatment. I need to, somebody who starts hospital-based and we're trying to reintegrate in the community. We want items that focus in on people who are bedbound, to getting out of bed, to able to walk around the block. Indeed, most insurance coverage is focused in this area. There's really no reason to give an item about how often I run 5 miles, etc. I could give physical function form B. This might be for, I'm looking at somebody who's an athlete, and they really want to understand, I'm tracing my ability from walking long distances to jogging to running to be able to run into a 50-mile triathlon. Please don't bother giving me items about being bedbound. That's not where I'm at or improving. Or I could have a short form that covers the full range of the trait. Now, if I give a full range short form, and that's not a bad idea if I don't know the population, but I have used some of my items, I've used some of my subject respondent time to ask about bedbound while I have some people who are athletes. So, computer adaptive test, custom individual assessment, suitable for clinical use. We'll get into that more in a few minutes. Custom item selection, PROMIS, NeuroQual in particular, allow you to go in and pick different sets of items, different diseases, different trials. Very often you get better face validity for your patients if you pick particular items. The PROMIS banks allow you to do that. So in summary, calibrated item banks can create a standard static instrument or a short form or a CAT, or you can do select content interests. But in every case, if you use a validated, pre-calibrated item bank, any of these instruments create a pre-validated scale and produce a standardized score on the same scale. So it doesn't matter if it's a short form, a long form, or a CAT, the score will be on the same scale. Now, the reliability will be different for a 3-item instrument versus an 8-item instrument, but we can compare the scores between studies, between trials. Let's talk about CAT for a few minutes. Computerized adaptive testing. Some people say computer adaptive testing. So what is it? Shorter, targeted, computerized algorithms. Who uses this? This is not bleeding edge anymore. I mean, I think CAT was really popularized using the ASVAB, the Armed Services Vocational Aptitude Battery, given by the Army, given to over 1 million high school students a year. It's used to assess abilities and aptitudes relative to placement in the military. This was a test. To some degree, it was developed to deal with cheating, something we don't usually deal with in outcome measures because you're given 1 million times a year, because recruiters get bonuses based on how many people they recruit. Maybe some recruiters were telling people what the right answers were. Maybe there were answers posted online. But CAT, one thing it does, gives a unique test to everybody, and that's a lot shorter. So CAT for certification, nurse anesthetist, Microsoft certification, CompTIA, computer technology, something, Association American Society of Clinical Pathologists, all these groups use CAT to reduce cheating, reduce test length. Licensure, boards of pharmacy, dietitians, National Council of State Boards of Nursing, tests over, I think, 100,000 people a year. Tests used to be 12 hours, given twice a year. It's now given every day of the year. Typically takes a little under an hour, hour and a half. It's more reliable because it zeroes in on a person's ability level quickly. College entrance, GMAT, test of English as foreign language, graduate record examination. These are all tests that used to be given only 3-4 times a year. They're now given almost 200 times a year, and the test length is greatly reduced. And education, NEA, and Renaissance Learning, those are the MAP and STAR tests. If you have children, 90% of kids in this country take one of those 2 test batteries to assess kids' ability, either multiple times during the year or relative to how they're doing compared classroom to classroom, things like that. These are CAT tests kids take. So what is a basic CAT? And this is a CAT for ability. We have low-able, high-able people, and the nice thing, we'll talk about a passing test first, so this would be like a certification test. We know a person's ability, so we ask them a question at the pass point. They get that question correct. Therefore, we give them a harder question. They get that wrong, not so happy. Give them a little bit of easier question. Get that right. Give them a harder question. They get that right. They pass their test. Now, to be honest with you, we've shown that a person is able to pass questions above the pass point. They pass the test. There's no reason to ask any questions below the pass point because they're able to ask above it. I've been the consultant for many, many certification organizations. I can assure you no one does it in 4 items. Let's look at a few more examples. I've already discussed how long you set a test. Here's another example. This is not as happy as an example. First item, they get it wrong. Give them an easier item. They get it wrong. A lot of frowny faces. Third item, thank goodness they get one right. Give them a little harder item. They get it wrong. They fail the test. Why do we fail? They're not able to answer easy items here. We don't bother giving them high-able items. They fail the test. So one thing to remember here is that most certification exams today are 60 to 90 items. They're that way because, first of all, if I really failed or passed someone at a certification exam, let's say a surgical board exam, these people have been in school 25 some odd years, people don't really like knowing even that they pass in 4 or 5 items, let alone 10 or 15. It's usually content balancing to make certain that they ask items about different areas that they work in. But for many people, we really only need 5 or 10 items. If a person is very low or very high, we're pretty much done. Don't like giving extremely short tests. There are some people who are very test anxious, and they screw up the first few questions and they recover. But after 10 questions or so, if you're consistently not able to answer easy questions, you're going to fail. Consistently answer high-level questions, you're going to pass. We're just exposing content we don't need to expose. So we're going to do binary search. I've never done this in a remote environment. Dr. Rothrock, can I grab you?
All right.
So ordinarily I'd get a volunteer from the audience, but we're going to do a little, here, Monica, I need your help too. I'm sorry, we got 2 people in the room. Now, we haven't practiced this in advance, I can assure you. I know it's hard to tell like this, so they're saying, uh-oh, because they're not sure what we're talking about here. So we're going to do 2 things. Dr. Rothrock is going to guess a number between 1 and 100. She's going to not guess a number. She's going to pick a number between 1 and 100 and not tell me. And Monica Prudencio is going to count how many questions it takes for me to answer this correctly, and I'm going to hope I do this right. Okay, Dr. Rothrock,
yes.
You got it?
Yes, yes, I do.
Okay, so is that number greater than 50?
No.
Okay, it's less than 50. Is that number greater than 25?
Yes.
Okay, is that number greater than 37?
No.
Is that number greater than 31?
No.
Is that number greater than 28?
No.
Is that number greater than 26?
No.
Is that number 26?
Yes.
How many questions?
7.
7, yay. Sometimes it takes me 8, but that's because I made a mistake. All right, so let's see what happened here. In a normal test, I was able, if the first question ascertained is below 50, I just cut my test length in half, right? Because in a normal test, I would have to ask 100 questions on paper. Is it 1? Is it 2? Is it 3? Is it 4? All the way up to is it 100? But after my first question, is it less than 50? I was able to cut the test length in half, right? I never had to ask questions 51 to 100. Next question, is it greater than 25? I've now cut test length by 75%. I know my answers are between 25 and 50. I'm able to narrow it down in 7 questions. And indeed, if there is no error in testing, I could completely differentiate people in 7 questions. Turns out usually there is error. We saw those information curves, so it could take longer than that. It depends on the level of accuracy we need. So let's talk about ability test here. So 2 things are happening. With each successive item, standard error decreases. You can see we're giving items that are currently at grade level -2. That's getting easier and easier. They get 3 items wrong. We give them a little easier item, the first green item down here. They get it right. Once they get one right or wrong, we can keep giving items right, correct, correct, incorrect, etc. As we give each item, our standard error decreases. The accuracy of our assessment is somewhere in this range. This is not relative to item response theory. Any test has error associated with it, and the more items we give, the more accurate we are. So after 25 items here, we know this person's ability falls as a whatever % chance we want to dial in, typically 95% chance that that's their ability range. Now we can apply this to their fatigue range, and if all I need to know is the average of 100 people, we can do this in 5 or 6 items. We need a highly accurate ability estimate here. Now these are for dichotomous items. Standard error reduces relatively slowly. On a board exam in the past, this might have been 500 questions to get here. Because it's a computer adaptive test, we're giving items trying to zero in on the person, so that several hundred item test is now only 25 items. Now let's look at a computer adaptive test for patient report outcome measures. This animation is courtesy of our colleague, Dr. Karen Cook. So we want to ascertain a person's level of physical functioning. So again, we have our item bank. We have varied levels of items. We have items, we have a ruler, the scale of measurement, and we have items that go across that ruler to help us zero in items that are associated with each level of functioning. So now we have on the right a person of unknown physical functioning ability, and we have our CAT algorithm on the left. So our CAT algorithm says to start, we don't know anything about this subject, patient, participant. So we're going to ask an item about in the middle of the trait continuum. We ask this item of this patient. Turns out that they're an avid soccer player, so they're going to do quite well on that item. So we go out next time and look for an item that's much higher. And now we've got 2 items. We apply some very funky maximum likelihood calculus. For those of you who like to fall asleep on this, we can discuss this afternoon, call me. But in the background, we're calculating this person's ability, their physical functioning ability, by looking at their pattern of responses relative to the item difficulties and able to zero in on their ability level. We know it's higher. By giving more items, we're able to get an increasingly accurate assessment of their physical functioning level. By the way, we are able, in something like physical functioning, for a median of 3 to 5 items, come up with a clinically reliable assessment for this individual, and this is opposed to 12, 15, 25 items, an assessment of only 5 or 10 years ago. Now we have another example. I'm pre-letting you know that we have a person here, has very low physical functioning. So we first gave them item at the middle. We found out that they're low level, so now we're going to give them a lower level item. And we will continue on. Now let's look at a comparison of the CATs for these 2 individuals. After 1 item, we know that their standard error places them in their respective green ranges here. So after 1 item, we know that this person is likely to fall in this range. This person's likely to fall in that range. After 2 items, we've narrowed the likely range of functioning. After 3, it's more narrow. After 4, it's even more narrow. So when do we stop? We can stop after a specific number of items. We can say, hey, we're done. We can't take that much more burden. But usually we stop after specified level of precision. And the level of precision is pursuant to what your goal is. If you're doing a clinical trial and you're trying to see, does this drug increase physical functioning, then giving 2 or 3 items to a large group of people will give you an accurate average to compare. If you want to do it clinically, actually with our CATs, 3, 4 items, and you're going to be able to get a clinical level precision again in median 3, 4 items. Some people may take up to 5 or 6 or 7, but that's it. So why bother with all this? We can reduce the burden of responding. Think about it and give you, using PROMIS instruments or the toolbox instruments, we can give you an accurate level of functioning on a patient-reported outcome measure, and it's used 4 or 5 items, not 90 items. I mean, a popular fatigue instrument used to be 90 items long as recently as 5, 6 years ago. All I know is after I took 90 items, I was fatigued. Now we can get that same level of reliability in only 4 or 5 items. And it actually makes room for measuring more domains. And we're able to find that you can give a PROMIS CAT and the NH Toolbox emotional health measures typically in under a minute, depending on your population, sometimes as little as 30 seconds, and you can get a clinically reliable level of functioning for that person. NH Toolbox cognition measures take, for instance, a cognition battery takes a 3-hour assessment, gets it down to 30 minutes, individual measures in as few as 90 seconds to 6 minutes by utilizing the same thing, drastically cutting the amount of time it takes to get an accurate score. So what do you need for CAT? You need a calibrated item bank and administration software. You need a starting rule. You need to have items which provide a lot of information. And if you're doing an ability CAT, you may want to cut scores. Say, once we know the person's above or below, we can stop. Typically in PROMIS and NH Toolbox, we're looking to get an accurate level for the person regardless of any particular cut score. So we can set stopping rules based on fixed length, variable length, looking at subtests, precision, pass-fail, maximum item count, minimum item count, lots of things you can dial in, or you can just take the default and be happy about it. We actually have 2 algorithms in use at all times. One is we're estimating the person's ability level, so we are taking the responses they've given to a given set of items and calculating their ability level, what we know about them. And at the same time, we're using an item selection algorithm, knowing what their responses have been, what's the next item we should give them. We base it on test difficulty. Again, we could, if you remember early on that one parameter algorithm, we can get a 50% correct experience. We could give people purposely slightly easier items, get them get 60% correct. We could deal with things like letting a person not get too high or too low, all sorts of things. Here's another ability-based test. This is going down. This is the pass point of a test. These standard error bars is really this asterisk, and the X is the person's ability estimate. And we see here that within 6 items, this person's got a 95% chance above being the pass point. We could pass this person on the test. These are the items they're giving, content areas, item difficulties, the answer they gave, how much time. We can track all sorts of information here. Now, again, this is a certification candidate, and they really don't really appreciate knowing they passed in 7 minutes. But they have this person's ability. Now, look at this. After about 10, 15 items, this is a person's ability estimate. It is extremely stable. It's in a narrow range, and it's not going very far. Doesn't matter how many more items we give them. And this is a group that used to give 100 some odd items, or I think 150, and you can see, again, we know they passed for sure, 95% chance within 7 items, and we can say we even have an accurate estimate of their ability 10, 15 items later. Clear fail example. Here's their ability estimate. Look here, by 13 items, we know exactly their ability estimate. It's right on the line here. You know, with 95% chance they're going to fail by 10 items. I usually recommend giving these people 80 to 90 items. I don't want to sit in front of a judge and say, Judge, you know, gave them 10 items, we knew for sure they're going to fail. And somebody else saying, oh, Judge, they gave them 80 more, they would have passed them. Well, if you can't pass items below can't get items correct below the passing point, you're not going to get them better above. Fence sitter, again, this only is applicable to passing point, but there are people, if your ability is on the passing point, that's where your ability is, and you have to decide, do you pass the person to pass or fail them? It's a qualitative decision. So now let's look at a cat for the same cat example. I have a lack of energy. Here's our first item. You've seen these bars before, a little bit different color. So going on under the hood, after one item, we have their ability estimate, we have the standard error, we know they're in that range. We have over here on the promise scale, measure of 37, standard error of 21, huge standard error, right, but only one item. Give them 2 items, our standard error decreases a lot. 3 items, again, by the way, we're simulating a person with ability of 48, so our estimate after 3 items, 42, standard error 9. 4 items, 44, standard error 8. 5 items, 45, standard 7. You can see we are zeroing in on their ability level. The standard error is decreasing. These bars are the information for each answer, and you see we're shooting this person items where the middle response is right at their ability level. Simulation measure of 15, that's a person 3.5 standard deviations below the mean, a very difficult person to assess. After one item, their ability is 9, standard deviation 38. After 2, 16, standard deviation 13. And we can keep giving this person items. And you see the middle categories here. We don't really care this category over here because we're trying to zero in giving them appropriate items. And you can see we're within one, heck, right up front, we're within 1 unit, a 1/10 of scale score unit. One scale score unit after 2 items, and we're right in the money all along. We just keep giving more items to reduce our standard error. And similarly, at somebody at the high end, 92, this person's 4 standard deviations above the mean. In this particular bank, we're going to see very rapidly, and this changes for every bank, we don't have items that are that high. We're not typically dealing with in fatigue. We're not usually asking people with fatigue, how much super fatigue, how much super energy do you have? Dr. Rothbard mentioned earlier, we're expanding the physical functioning items there. You can see towards the bottom here, we're giving items where the middle category is far away from the person. This is a ceiling effect. Means that for a person whose ability is 4 standard deviations above the mean, we don't have good items there. But look, even with that, our scores are in the ballpark for this person. Again, this is an athlete being asked about their fatigue. You're not going to have it. If we had a problem with a person, this would be a floor effect here. I think that's it. I think we're right on schedule. Are we taking questions? I think we should. No questions, good. Then we're going to go on. I'd like to introduce Monica Prudencio, is going to talk about how you get access to these instruments and how you can use them. And let me see if I can, let's see, I'm going to, no.
So while we're transitioning slides, if you would answer the polling question that we've opened about what data collection platform do you know you can access, that would be great. Richard?
Mm-hmm.
Okay, great. We're going to talk about data collection options. I have been working with Assessment Center for 5 years, and over the 5-year period, we have seen lots of movement in data collection options, as well as development within Assessment Center. And so we're going to talk a little bit about these options as we roll through this. So typically, data is collected on paper. It's available on short forms. The downside to this is it does require manual data entry, so that could be error prone. Scoring is not automated, so you do have to use scoring manuals. PROMIS and NeuraQual do have ready-to-use PDFs available through Assessment Center. And so that is always an option that you have for administering these types of measures. Why would you use online data collection? Well, first of all, it makes more sense geographically. If your sample size is dispersed throughout the nation or the world, online data collection makes it much easier to collect data in a centralized area. There is no need for data entry staff. These are person-centered outcomes, and so the person would be responding directly into the system. There is time-date verification on the data exports. Accessibility, font sizes can be increased, their screen readers can be used, their items can have audio, and so this does increase your sample size and being able to reach out to a larger community. Data is backed up nightly. The item and instrument randomization occurs much more easily online. Again, the system is doing that for you. And then there's, also IRT administration and IRT scoring, which after Richard's presentation, we definitely know a little bit more about. So available systems, I'll say, a couple of years ago, there were many less systems available than there are now. Assessment Center is available to all users. It's in the public domain, so it is available to you. Right now, there is also an Assessment Center API, which we'll discuss a little bit more about. REDCap and EPIC. There's also Bright Outcomes, Madigan Army Medical Center, SOSCN, OBERT and Lambda. They're interested users, and I'll talk a little bit about this a little later on. There's also this Assessment Center iPad app that is in development right now, and the list grows and grows. I think since this slide set was put together, there's probably some more interested users, so and growing, will continue growing. So Assessment Center, why did we create it? PROMIS and NeuraQual had an investment to create item banks that can be administered as CATs. At the time, there wasn't an off-the-shelf platform for CAT administration. And so what better opportunity for us to create a platform than at that point. What we've learned over time is that researchers typically use more than CATs in a single study, so CATs in sequential forms. And over time, there came Toolbox. And for Toolbox, it was required that there be a platform that could be used for self-report and proctored administered outcome instruments. And so Toolbox was then implemented within Assessment Center as well. So what is Assessment Center? It's a web-based research management tool. I like to call it a data collection tool. It's not a tool for IRT analysis, but it's a tool to create your study and administer the study, so present the items to your patients for data collection. As I mentioned, you create a study within Assessment Center, and by the creation of that study, each study has a unique URL. There are no two URLs that are the same in Assessment Center. And within those URLs, the patients enter in their logins, and they respond to items within that URL, and data is collected specifically to that study. So it's a participant interface for data collection. Assessment Center does administer PROMIS and NeuraQual and NIH Toolbox short forms and CATs, and there is the ability to have items where the researcher the items are only completed by the researcher. A user of Assessment Center can create custom short forms. And then there is also single time point or multiple time point studies, also known as longitudinal studies. So it is quite flexible. I mean, there are other features that Assessment Center has. There are multiple study arms, randomization of items and instruments. There's accrual tracking. There are measures that are available in Spanish for Spanish data collection. The real-time data exports, and the PRO data is separated from the registration data, any PHI, and consent data, as well as there's an automated data dictionary. And I'm just actually scratching the surface of what is available in Assessment Center. I'd like to say that if you can think of a study, then Assessment Center can handle it. So there is learning on Assessment Center to do, but again, we're here to help you through that process. Assessment Center is sponsored by the NIH. The sponsorship comes through the hardware and the software maintenance, any new feature development, as well as the help desk. I'd like to emphasize that there is a help desk. It's a tool available to you, and as you scratch the surface within Assessment Center, there are questions that come up, so please use the help desk as support. In the future, there will be support and hosting fees, and contact information is help@assessmentcenter.net. Assessment Center holds an instrument library. It's a distribution mechanism for PROMIS, NeuraQual, and Toolbox. For Toolbox, you first need to ask permission to use Toolbox measures. Right here on this slide, there is a URL on where to ask for this permission. You could also go to just nihtoolbox.org, and through the How Do I menu, you can find how do you request access to the NIH Toolbox. All the measures that are available within Assessment Center are available also is downloadable PDF, but I will emphasize, as I stated earlier, that that is for Neuro-QoL and PROMIS. More information on Assessment Center. AssessmentCenter.net is the URL and how you get to Assessment Center, and that's our homepage. And on the homepage, there's a wealth of information, what measures are available, scoring manuals, a user manual, video tutorials, a help section, an FAQ section, and access to the help desk, as well as there's also a CAT demo, so you can see how the CATs perform in Assessment Center. So the Assessment Center API, well, what is an API? The API exposes the Assessment Center library for external system consumption. I'm going to flip over to this next slide here. And this really shows you what will happen with the API. The API will be installed within your institution's firewall. Your local institution would provide a server's software administration, so a patient-facing portal where patients can respond to the items. That portal will call the Assessment Center API to administer the items or the instruments that you have selected for administration. So the benefits of the API is that it does run locally. The data is contained within your institution's firewall, but at the same time, new content is always available. Over here on the right-hand side of the diagram, you'll see this Assessment Center library. So every time new content is released, the API, your API installed at your institution can call the Assessment Center library and bring in new measures. So as I mentioned, you know, the benefit is it runs locally. And so if there are any legal reasons why data needs to stay within your firewall, well, this is a solution that we've come up with. Currently, the Assessment Center API, there are a limited number of PROMIS banks available for use, and those are available now. By the end of summer 2014, we're hoping to release version 2014, which will include PROMIS banks in short forms, and they may include Neuro-QoL and NIH Toolbox self-report measures. This will not include the cognition, motor or sensory measures for Toolbox. There will be a flat fee per server installation. And this is a good example of, well, who's using the Assessment Center API? Right now, REDCap is. We'll talk a little bit more about REDCap in just one moment. SoftSkin is, and Madigan Army Medical Center with the DOD is using the Assessment Center API. And some interested users are Cerner and Pearson, Ortec, McGill up in Canada, Oberd, and Lambda. I've listed the domain, the URLs for each of these interested users if you'd like to learn a little bit more about their systems. If you have any questions about Assessment Center API, please contact us at help@assessmentcenter.net, and we'd be more than happy to answer your questions. So REDCap. So REDCap is a web-based data collection tool for research purposes. Initially, it was focused on researcher-completed data. Over time, they've opened that up, and now there is a portal for patient-reported. There are audit trails if data has been updated, user activity. They do have data exports. A project calendar is available to you to let you know if there is action to be taken. For example, our example here is if the patient needs to have any blood drawn. A scheduling module, so longitudinal studies can be set up through REDCap. There's an ad hoc reporting tool, and so this really drills down to more information on data collected, perhaps the number of men versus the number of women, what's the average score on items. It does allow for branching logic, data collection in multiple languages. One thing that I thought was very interesting is the number of active partners and number of active users. So REDCap is a large community and continues growing, and we know that with the API it will continue growing. So what is available in REDCap? PROMIS short forms are currently available. And by the fall of 2014, we're going to expand this library to include PROMIS short forms plus CAPS, PROMIS CAPS. There is no cost for REDCap partners. And if you have more information, or if you have more questions about using PROMIS in REDCap or just REDCap, please contact REDCap directly. EPIC. So EPIC is currently, there are PROMIS short forms available in EPIC. Currently, patients will respond to items through MyChart, which is the patient portal. EPIC does require a specific version of installations at local sites. And so it would be good to talk to your site to see what version of EPIC they have. The measures are scored in real time, and they are available in the medical record. PROMIS short forms are available through EPIC. There's a limited number of PROMIS short forms using raw scoring in EPIC 2012. For the fall of 2014, there's going to be a larger set of PROMIS short forms with IRT scoring. And then by 2015 or 2016, PROMIS CAPS will be available. So direct your inquiries directly to the EPIC MyChart team. There will be no cost for the EPIC user, and contact information is info@epic.com. Bright Outcome. This is another group that uses health technology that is focused on PROs, and it enables their customers to measure population's health status, inform their clinical or researcher decisions, and empower their patients and subjects and healthcare consumers. They have a collaborative symptom management system which focuses on chronic conditions. Data collection is available through the web, phone, and handheld devices. They have single and multiple time points available. The patients complete their information through the system tracker. So a history of side effects and symptoms can be created. There can be a link to reliable educational information, and it could alert the patient on when to call their provider for concerning problems. Their treatment tracker can combine the patient-reported outcome data with clinical treatment records. So what is available at Bright Outcome? PROMIS item banks and short forms are available. They're available the summer of 2014, so now. You'll have to contact Bright Outcomes for more information, and here's two contact information directly to Bright Outcomes or to Dershong Yang. The Assessment Center iPad app, this is something that is under development currently. It will allow for offline administration of the NIH Toolbox and PROMIS instruments on the iPad. This will include instrument administration, scoring, recording, data aggregation, and data export. There is no study management on the Assessment Center iPad app. Right now, we are field testing the app. In late 2014, early 15, Toolbox Cognition and Emotional Health Measures will be available for a select group. And later in 2015, most of Toolbox and a majority of the PROMIS instruments will be available. There will most likely be a fee for downloading, and complete licensing information will be available late 2014. If you have any questions about the Assessment Center iPad app, contact us at help@assessmentcenter.net and we'll get you the information that you need. So how do you know what data collection tool to use? Things to take into consideration, what types of instruments are you using? What types of items? What is the mode of administration? Is it an iPad versus web? Is it will you be collecting via phone? What's your study timeline? Is it one time point? Is it longitudinal? How many languages will you be administering the study in? And where can data be stored? And let's see, there we go. Do you need some automated reminders or prompts to the patient or to the study team? Other things to take into consideration is real-time analysis. Is accrual tracking important? And what about the calculating the means? And what's your funding like? These are all specific things to think about when deciding which tool to use. I like to think that if your institution uses any of the platforms discussed, that we suggest that you use your institution's platform for data collection. And so take that into high consideration when deciding which data collection tool to use. This is a brief demonstration on what systems are available out there, and any questions that you do have can be asked to specific systems or to help@assessmentcenter.net, and we'll help you try and decide what tool you can use. And that's it.
Okay, thanks, Monica, very much. If you would pull up the closing slides there. We're going to, let's see here. Can we pull the polls? Nan, I think that might be nice. Maybe to do it off that question. What we're going to do is if you have questions, please send them that you'd like answered during the course of our webinar. Please send them to the Q&A grouping. We have been answering throughout the session. What I'm going to do is we're going to go back. What? The poll?
Yeah, we can't view the polls.
Oh.
I can tell you the poll results.
Okay, I have them. So we can, yeah. We'll go over the poll results. Then we'll go over some of the existing questions you can see on the screen, by the way. Important thing to learn more. Are we viewing?
Oh, yeah. Thank you.
Great. Do we have confirmation? Yeah, we do. So in case you're about to duck off, but we will stay on when people have questions, best places to learn more are about at nhpromise.org, neuroqual.org, neuroqual.org, nhtoolbox.org, or help@assessmentcenter.net for direct email questions. We have video tutorials, a lot of publications, lots of manuals. We'll probably be a little flooded with questions over the next few days, but if you don't hear from us usually within a few days, we do have people online full-time. We answer internet inquiries first, and if you fill out the little form, it helps us direct your question. If it's a particularly scientific question that's of narrow interest, we'll forward it to a scientist who has the best ability to answer that question. So what I'd like to do is go over the poll results, and then we'll go over the QA questions, some that came in earlier, and some that are coming in right now. Again, best place to do is to chat to QA and not chat to host. We'll get to the host questions at the end of the presentation if we have time. I think we just lost our live thread, but we're okay. We're at acknowledgement stage there. Okay, so Nan, you want to take it away on the poll results?
So the first poll question was what people were interested in doing, and the majority of folks who responded are interested in clinical research, with some folks interested, with a minority of people interested in clinical care and performance measurement or other issues.
Okay.
The second poll was asking, let's see.
Primarily interested in PROMIS measures. Most of PROMIS measures are all the measures.
People are interested in all.
And I think that's the other poll result here is just that 28% of people, 18% of the people on board have access to EPIC, and that's the easiest way to integrate the PROMIS measures in clinical workflow or for research. To remind you that the PROMIS short forms are currently available in the EPIC PRO library. That's a free feature available within MyChart and MyChart Setup. I urge you to talk to your internal MyChart support team to get that. All PROMIS short forms and will be available with IRT scoring at the end of the calendar year within EPIC 2014, and we're not sure yet if it will be backwards compatible with EPIC 2012 or 13. And EPIC has assured us that in EPIC 2015 or 16, EPIC Care 2015 or 16, all the CATs will also be available. So it's just a normal measure within MyChart. You can use it to directly push data into the clinical workflow. And if you're interested in the CAT measures, I urge you to talk to your local EPIC representative, and I urge them to get in touch with EPIC to remind them of how important it is to you to have those measures. They very much add features based upon input from their users. 28% of the people that responded on the call have access to REDCap. As Monica indicated a few minutes ago, all the measures in our API, which are currently the base PROMIS CATs and will later in the summer include all short forms and PROMIS CATs and all the NeuroQol measures and NIH Toolbox emotional health measures will be available directly in REDCap. That's now in field testing at Vanderbilt and will be available to all REDCap users by the end of the summer. Rumor has it'll be a little bit earlier. Dr. Rothrock.
I was going to just give you some of the questions that have come in.
Great.
So the first question is prozetastone the only way to obtain cutoffs or to categorize scores as mild, moderate, severe, or to relate a score with a clinically meaningful cut point?
There are literally over 150 research papers published on the various instrument sets we've been dealing with right now, and some of those are very much have to do with use of these instruments in clinical practice, and you can look on the respective websites, not do a web search, and there are some of those research studies have indicated areas of clinical interest. The way clinical cut scores are traditionally set is goes through some kind of standard setting process, and using prozetastone, you can see the equivalent cutoff. If you know the cutoff on SF36 or on a BDI, something like that, you take these scores on that cutoff that were developed for those instruments and equate them to the scores on a PROMIS instrument. That's the fastest way if that hasn't been done. You could look into the clinical standard setting that have been done by others, and a lot of these are in progress. So lots of different ways. I'd say we're in the infancy of having a single sheet of paper that says what the cutoffs are. It's not something that PROMIS itself is likely to provide soon, but you can get these things online, and Prozeta can help enable that.
Great. So another question that's come in is if there are measures that map on to classic measures of basic and instrumental activities of daily living.
Are there measures coming in for ADLs, basically?
So does PROMIS NeuroQol Toolbox have any measure that would respond, that would capture the same construct as other measures on basic and instrumental activities of daily living? I'm
going to answer no, but I may shoot this one right back at you, Nan, because I'm unaware of any instrument that would directly capture that in this grouping. The one problem is a very large development effort, and we're always not sure who's working on what.
Yeah. I think one of the issues, basic activities of daily living, dressing, bathing, feeding, some of that's going to be covered in physical function measures. Instrumental activities of daily living are often looking at things like ability to work, ability to fulfill your normal role, and those are going to be spread out in other domains. So you might see some of those issues pop up in measures of social function or in physical function, depending on the content. One common question that's come up is if we're going to be sharing our slides.
So we will post slides on assessmentcenter.net, and it may be on some of these others. Whether there's a link, give us a day or two. Someone's also asked, will we post the Q&A answers? We will do that as well. I think that covers the external pieces. There is a lot of content available for Promise, NerdQual, and the NIH Toolbox. Typically, a Google search will find those or searches within the website, although I find the internal search tools of the websites won't necessarily find it there. So do use Google as a whole. And if you don't find the answer you're looking for, please send us a question. I find search engines don't always find what seems obvious to you, but we will post all those materials sometime in the next 2 business days.
Another question that came in was, how do the Promise mental health instruments compare with DSM-5 questionnaires online and in appendices? And so one thing is that some Promise short forms are actually included in the DSM-5, certainly for depression and anxiety symptoms. Promise is not a diagnostic measurement system. The DSM-5 is intended to be a diagnostic system, and so Promise measures can be utilized to assess symptom severity, but should not be used as a tool for diagnosis. So for example, in depression, the Promise instruments, nor NeuroQual nor Toolbox, include items about somatic symptoms, because when we are working in chronic conditions, those symptoms are often caused, or the etiology is the disease of interest, not a depressive condition. So those are excluded. So if you were using a Promise measure, you would, and were interested in a diagnosis of depression, you would need to supplement that with some assessment of cognition.
So a question now, is there an advantage in using Assessment Center versus Bright Outcomes or EPIC using Promise? Monica indicated before, it's been our experience, and we've been at this game relative to these instrument batteries for close to a decade. It is typically easiest to collect data, and particularly if it's in clinical settings, in a closest manner as possible to the clinical data systems that people are already using. So my first answer would be, for instance, if you're using EPICare, if you have access to EPIC, I would put them straight in EPIC. Therefore, results can be directly available to a clinician. You can put it in the clinical workflow. So that's EPIC. Assessment Center versus REDCap. A REDCap enables you to store your data on your server associated with your cells. I think there's something like 980 some odd REDCap servers. Are very typically behind a clinical firewall. They're located locally. Assessment Center currently is a single server located at Northwestern University. In terms of use, you'll see that we treat it as a business associate's license, so we do not reveal data, we do not access your data, but a lot of clinical institutions are not comfortable with that, so having a system that's located locally is worthwhile. Typically, you can get access to that for free, and you have more features. We developed Assessment Center as a mechanism of doing this when there was none, and now there are many. Bright Outcomes is a private organization. They developed administration software under SBIR funding. They are experts in PRO assessment, and they may have features that match what your needs are. So part of it is looking at your own individual needs and where you're set up. Let's see here. I think we'll go back up to the top, I think, if we so an early question is, how do you derive the T-score? I'm hoping people know that now, but to refresh your memory, T-score in PROMIS instruments and is the number 50 is the mean of the generalized population. One standard, each 10 points is one standard deviation distance from that. So a person with 60 is one standard deviation higher than the general population. The NIH Toolbox instruments, many of them use a scale of 100 standard deviation 15, which is more in keeping with neuropsychological testing. So you do need to know which measurement system you're using. Dr. Rothrock.
There's a question that came in to discuss a little further the difference between self-report of cognitive function and an objective assessment of cognitive function.
Good question. Actually, there's no such thing as a bad question. Okay, so self-report instruments generally have been found to correlate very highly with objective measurements of everything from depression to fatigue to even cognitive functioning. But it is an assessment of how a patient feels about themselves. So it is possible for someone to have a high IQ and find they're having difficulty with their cognitive functioning. So the self-report gives you what the patient's feeling about themselves, particularly with meaningful use requirements and patient-reported outcomes with the creation of groups like PCORI. There's an increasing emphasis in healthcare on utilizing the voice of the patient. And probably the easiest correlate with voice of the patient is looking at what the patient says about themselves, and that's what the patient-reported outcome measures say. Now, an objective measurement, something like depression, the only way we currently have to assess depression is really asking patients about their depression. There's no objective, there's no number we can plug in. We're always asking patients. So all assessments of depression are patient-reported or proxy-reported. That's not the truth with cognition. Cognition, we actually have multiple ways. We can assess it through self-report. We can assess it by giving a cognitive battery and give objective instruments that give test questions and see how that person is acting. And we can also use proxy measures. And depending on the type of research you're doing, you may need 1, 2, or all 3 methods. Obviously, self-reportive cognition, giving a PROMIS CAT, we can get probably a clinically reliable measure for the median person in 4 items or so, up to 6 or 7. In a cognitive battery using the NIH Toolbox, vocabulary test could be had in 4 minutes. A complete neuropsych battery is going to take closer to 30 minutes. And a proxy measure similar to the self-report measure. So it really depends on what you're using it for. See, we're trying to. Someone asked earlier, are there measures of carrier-reported cognition being developed? Not to my knowledge at this time. There are proxy measures available within PROMIS. NIH Toolbox has quite a few additional measures. Now, in PROMIS, the proxy measures may be for pediatrics or may be for people unable to respond. In the NIH Toolbox, the proxy measures are are not available for the elderly, but they are, or the cognitively disabled, they are, I'm not saying that all elderly are cognitively disabled, but for elderly who are, but there are proxy measures of emotional health available for ages, I want to say 3 to 15, if you want to do that, as well as that there are self-report measures available for elder children ages 7 on up. So you need to explore each battery relative to your construct of interest. Someone asked about FDA endorsement of these measures. All of the PROMIS measures, NIH Toolbox measures, self-report measures anyway, have followed FDA guidance in how they were written, created using the voice of the patient in the construct development and in item development, extensive cognitive interviewing with patients, both for the initial banks and with translations. The way an actual FDA endorsement works is for the instrument is presented within context of a specific disease, and there are several instruments in PROMIS and usually within a trial. And there's numerous instruments that that's undergoing right now. FDA representatives have been on the PROMIS steering committee since the beginning. It's just that to say FDA endorsement is actually overstepping that bounds, but the FDA has endorsed use of PROMIS instruments in applications. And so if you understand what I'm talking about, I think that's a good answer. And if you don't understand what I'm talking about, trust me, it's a complicated process. Go ahead. Monica?
There's a question that came in saying, how do you compare PROMIS depression short forms with standard measures such as the SCID, Mini, or Hamilton? Do you have any reference to that?
I don't. Nan?
So what I would suggest doing, I don't know off the top of my head if those have been compared, I would go to the PROMIS website and find the link that says publications. There's a section of publications by domain, and I would look at the depression pubs or search for Paul Pilkonis to identify if in what studies PROMIS depression may have been compared with some of those instruments. I do believe there are comparisons with the CESD. That's on the Prozetto website. You can see the cross-linked tables. I don't know about the Hamilton. I don't know that I've seen that, but it might have been done by Dr. Pilkonis or others.
Earlier question came in is, what is the oldest age range applicable to the PROMIS score? So the calibration testing sample for PROMIS included 20% of the sample over age 75. The NIH Toolbox norming sample actually ran from 3 to 85 and included, there's a lot of overlap of emotional health measures in that range. So these instruments have been used up to 85. There are quite a few. I actually had a call at 7:30 this morning about the use of NIH Toolbox emotional health in 85-plus sample. So there's been a lot of normative and validation work done in those areas. Again, you can go online, or if you have additional tests, there are quite a few senior researchers who are making use of these tools.
Another question came in, Richard. Quote, when we talk about what these tools are used for, the government is currently looking into the use of these kinds of tools to develop payment reform. Would you share thoughts about how PROs versus therapist-measured outcomes could or should be used to this end?
I'd love to say no comment, but I'll give it a shot. These are my own views and not necessarily those of PROMIS, NeuroQual, and NIH Toolbox. I think that we have a significant movement in this country right now to include the voice of the patient in healthcare. I think it's very, very important to include the voice of the patient. I think it is balanced with therapist-reported outcomes. I, for instance, believe that almost any clinical study with outcomes should include an assessment of depression, probably social support. You know, a person reporting on their satisfaction if they have depression, which very often accompanies treatment, they're going to downrate their physician and the success of their treatment accordingly. And it's important to know that it's important to take that into consideration. I think any single measure, while it's very tempting to put a single item or a single measure in the reimbursement equation, I think it's very dangerous. And I don't know who's going to draw that balance. I think the best way is to, again, get objective measures of performance, of outcomes, get patient-reported. And I would like to say patient-reported measures are objective, but they're objective from the position of the patient. Physician, therapist-reported measures are objective from the perspective of the therapist or physician. And you should all know, getting back to the FDA question, you can no longer get a label claim on a drug unless unless you're able to report that there's an improvement of a patient-reported outcome on some measure. So, I mean, if you biologically cure the cancer, but patients don't feel any relief whatsoever, you know, if you kill the patient, you know, we're not going to get a label improvement, you know, or kill them emotionally. So, I mean, there's a balance there. I think there's going to be an ongoing healthcare debate. Happy to weigh in, but I certainly don't have the definitive answer. Please.
Another question that came in. Do you have any sense of NIH perspective on using PROMIS CAP measures on NIH-sponsored intervention studies?
Certainly there's been a lot of positive feedback about using PROMIS in general research studies, and I would say be a completely fair response to say that the NIH PROMIS measures as a roadmap initiative, now common fund initiative. I think there's a lot of respect within the NIH. There are numerous cross-NIH and cross-HHS initiatives which are including PROMIS measures, Institute of Medicine recommendations endorsing PROMIS measures in various ways. I think it would be a logical conclusion that using them in interventional trials would be very positively viewed. Okay. So a question, you mentioned these tools are royalty-free. Are there other requirements to use them? Generally speaking, the requirement is you can't modify them and call them a PROMIS toolbox or NeuroQual instrument. There are limitations to modifications. Translation, we reserve the right to maintain translations. So there's a common translation. So there's one Spanish translation. There aren't 25 of them. NIH Toolbox measures, the cognition measures are not available in the typical public domain. We do not want cognitive measures to be posted. So they're freely available to researchers and qualified clinicians, but there is a limitation that they cannot be publicly exposed because otherwise you could have a patient or a subject in a trial going on and practicing the instrument. So there are some subtle things. That is not the case. Again, all the emotional health measures in PROMIS NeuroQual NIH Toolbox are freely available for use and freely postable and viewable. And again, the NIH Toolbox cognition measures are not. That's why the requirements are using NIH Toolbox. We need you to sign up online to use them. We track users a little bit more closely there, and there are over 1,000 researchers and clinicians have done so to date.
There have been a number of questions that have come in about what do you know about measure X in disease or patient group Y? And one thing I would recommend is to review, as I mentioned, the list of publications on the PROMIS NeuroQual Toolbox site. I know the PROMIS Site Best, it does have a list by domain, and so you can view publications by physical function, by global health. You can also do a search to look for keywords of interest, and that's kind of cheating. You can also do a full review in PubMed or Ovid, whatever your choice is.
So early question, will the webinar be archived? Yes, we will be archiving it, and we will post to all of you and post on our website the location of that shortly. Also mentioned working on updates of physical function for marathon or super athletes. Will there be similar updates for floor effects? Indeed, there was a Freeze et al. Paper, and Dr. Freeze was the retired recently, but was the primary domain leader for the physical function measures, and he recently published a paper on adding items to the floor. No definitive answer on when items will be added. We are we're really exploring how adding the floor effect items would help the PROMIS banks. Will be something reviewed in the coming year, and ditto for the ceiling. My guess would be the ceiling items will be added more quickly, but you have to stay tuned and please stay in touch with us.
One question that has come in is related to data analysis. There's some uncertainty about how one does data analysis with CAST or other of the newer measures we've described.
Okay, so nice thing is that whether they're given as a CAP or a short form or a long form, all these measures produce a score, a T-score, and you can utilize that T-score in any equations that you would use for analytic purposes. The score is a little bit more meaningful, and if you can talk to your analyst about the meaning of a deviation-based score, a T-score is that. But it gives you a score, a highly reliable score. It appears to be on a scale of 0 to 100. It's very easy to use analytically. And frankly, if you're using a longer form or a CAT, it's going to be a lot more accurate than a short score, raw score based, although there are raw score, scale score lookups of short forms if you don't have the ability to give a test in a computer-based environment with scoring in it. Okay, just a quick other review, last chance for questions here. Okay, anything else? Okay, again, if you have questions, hit the website, help@assessmentcenter.net is an email address. I do predict a slight backlog over the next few days. Really appreciate everyone signing in. We had several hundred people. So I think actually over 300 people sign up for the webinar, and we're thrilled that you all joined us. And thank you very, very much for your interest. I'd like to thank Dr. Nan Rothrock and Monica Prudencio for doing the yeoman's share of setting this all up. And Warren Francis, our technical director here, who's been helping us juggle everything in the background, and look forward to seeing you in the future or talking about any of these PROMIS instruments. Thank you so much.
Thank you.